ask the residents to describe the features, and we'll have a discussion on these slides. So this was the case 1 which was given. This was a 67-year-old female, left cervical lymphadenopathy for 3 months, no history of fever, pain or other constitutional symptoms, and no history of weight loss or loss of appetite. So this was a 2 into 2 centimeter mobile swelling at the level 5 in the neck. So this is the history which has given, and this is the low power view which has been given to you all. So can Dr. Sagar, can you just describe this field, please? Hello? Yeah. Can you just describe what you can see in this field?
I can see moderately cellular, highly cellular smear, moderately to highly cellular.
Okay. Okay.
I'm not able to.
Okay, so the cellularity, you can see the cellularity that the smear is quite cellular. Can you see any arrangement of these cells? So what happens at low power, that whenever we see cytology smears, we assess for the cellularity and any pattern of cells which we can see at a low power. Okay. So can anybody recognize any pattern on this magnification?
Small
Komal?
follicles, like, ma'am.
Okay, follicles. Okay. Which one? Anything else you can recognize?
Ma'am, one sheet looks like having papillary arrangement.
Yes, so it is not follicle. Actually, these are the cross sections of the papillae. So if you see these are the, you can see here a central fibrovascular core kind of structure. Okay, some spindle cells with some matrix, connective tissue matrix. So this is the core, and you have cells arranged around that core. So these are basically papillary structures or papilloid structures. Okay, again, this is the cut surface of that papillae, where you can see a central connective tissue, which must be the connective tissue of the vessel, and the cells arranged around it. So these are papillary tufts of papillae and papillary structures. Okay, now when we move on to high power, it is more clear. Okay, so you can see these connective tissue structures, although we are not seeing lumen here, but we are seeing these cells arranged around this structure. Here you can see a kind of fibrovascular core longitudinally with the cells around it. So how are the cells? Can anyone describe the cells? Cytomorphology, maybe we'll go at a little higher power. So can someone describe the cytomorphology? So at a low power, whenever we see a cytology smears, we see for the cellularity, whether it's mild, it's moderate, or it is very marked. We see for the arrangement of the cells, whether they are in a papillae or tubules or follicles, or they are in just diffusely arranged or in sheets. Okay. So here, what did we note? We noted that the smear is quite cellular. The cells are present in a papillary pattern. Okay. Yeah. And now we are seeing a little higher power, where we have to describe we have to observe the cytomorphological findings. How is the cytoplasm? How is the nucleus? So can anyone describe here?
When there is
Yes.
nuclear pleomorphism, and also the nuclei are enlarged, and some overlapping is there.
Overlapping. Not too many.
So you eccentrically located nuclei, ma'am. Cells with few eccentrically located nuclei.
Very few, some very occasional like this, okay, or maybe here, but mostly you see that the cells have a moderate kind of ATPL, because some are small, some are large, okay, and they have a cytoplasm is like moderate cytoplasm in most of these cells. You can see the cellular details in these cells better, and then the nucleus is It is not
Brown.
this small is not very good to see the nuclear chromatin, but still you can see that in some you can see some small nucleoli like here, and so the nucleus is also opened up kind of thing, and you have a like moderate cytoplasm which is slightly granular. Okay, so here you can see the cytoplasms. Then now this is another stain which is an H&E stain, and you can see this again papillary structures here. Here you can appreciate those core better. Okay, and these are the dispersed cells where you can see. So you have these loose disc cohesive cells, and you have this papillary or papillary structures. Now we move on to the higher power. Okay, so this is the higher power. So here you can see again, if you want to see the cellular details, you can see that they have quite moderate abundant amount of cytoplasm. Okay. Komal, you said there is overlapping. So what DD are you thinking? And do you find other supportive features for that?
Ma'am, I was thinking of papillary thyroid carcinoma.
Okay. Okay. So do you find those maybe a little bit of overlapping is there, but did you find other features, nuclear features to support that?
Ma'am, I not appreciate pale powdery chromatin here, but in some there was some visible nucleoli, as you also said. And also we need
Yes.
to see the nuclear grooving and intranuclear pseudo inclusions.
So at this power, you are at this stage, you know that there are no nuclear features of a papillary thyroid carcinoma. Okay.
Yes, ma'am.
So now, what is your DD? So Komal can give any one DD.
Medullary thyroid carcinoma. Some cells can have like plasmacytoid morphology, and they have some papilla.
Okay. Any Dr. Preeta?
Metastasis either from a breast papillary carcinoma,
So this is a cervical lymph node. Okay. So it has to be largely metastatic. Primary, we don't expect lymph node, no? So it is metastatic. So you said medullary possibilities like thyroid. Second, you said breast. Okay. Dr. Apurva?
Apurva is not there.
Apurva is
We have
okay.
only Dakshayani.
Okay, Dr. Dakshani, can you
Can it
have
be
any?
metastasis from lung tumor, ma'am?
Okay, lung, breast, thyroid. Anything else? Anybody can suggest? So now you have to remember first what are the papillary lesions that can metastasize to cervical lymph nodes. So whatever you have told till now are the common sites. Okay. Any other site anybody can think of?
Ma'am, nasopharyngeal.
Nasopharyngeal will not show you this kind of papillary architecture. There you see mostly disc cohesive cells, large cells with prominent nucleoli, and some lymphoid infiltrate admixed with that. So the prominent nucleoli is very classical, and you see loose dispersed cells, not papillary structures. Here you can nicely see a very well-defined core, isn't it? Core and cells around arranged around that fibrovascular core. So papillary lesions can occur where?
Ma'am, papillary renal cell carcinoma.
Okay. So the common sites metastasizing to the cervical lymph node are, which have these papillary lesions are lung, breast, thyroid, and kidney. Rarely, but kidney comes lower down. Okay. So most commonly you have to think about thyroid and lung. Breast is also less common than the lung and the thyroid. Yes. So if you again see these cytoplasm, you see again concentrate on the cytoplasm of these cells. So you rule out the papillary thyroid carcinoma because you don't have the nuclear features. Now cytoplasm is abundant. How is the cytoplasm? If I go back to the again this field and then in this one, so it is slightly granular, isn't it? They are granular, they are pale, they are not that dark or dense gray, just like scomoid or even like an adeno. Okay, so they are lighter, isn't it? So on further investigation, this patient was diagnosed as having a mass in his in the abdomen, in his kidney, and this is actually a metastatic papillary renal cell carcinoma. So whenever you are in a doubt, you see a papillary lesion and you don't know the primary, what will you do? What markers would you like to do if you have a facility for a cell block?
Ma'am, CK7 and CK20.
Why 720?
Okay, for what? CK7 and 20?
Ma'am, to determine the primary site of origin.
Gaurav, lecture on the
Sorry? Please say again.
Ma'am, to determine the site of
No, no,
origin.
no. Somebody else was saying something?
I think he was talking to someone else.
Okay, okay. So what, Shraddha, what primary did you think of? What were the DDs that we discussed?
Ma'am, lung,
Yes.
breast,
Yes.
thyroid,
Yes.
kidney.
Yes. So these are the common, sometimes maybe from GI, but very rarely. Okay.
Yes.
So to differentiate all these, what all antibodies would you like to have?
Ma'am, for breast, we would like to do GATA3.
Will CK7 and 20 help you for the breast?
Yes, ma'am.
How?
Partly.
Okay, how?
CK7, breast can be CK7 positive and CK20 negative, ma'am.
Yes.
We can have three DDs for that. Lung, breast, and thyroid. All three can be CK7 positive and CK20 negative.
So then what will you do?
Then after that, to
Other than
differentiate between to differentiate, ma'am, for breast we can use GATA3. Then for
Have
lung,
you
ma'am,
kept your somebody has logged in again with you, adjacent to you. Your voice is getting echoed.
Sorry.
yes.
You can log in at one. If you multiple people are there, you can just have a one login. Okay. Okay. Then GATA3 for
Ma'am,
breast.
GATA3 for breast, and it can also be positive in urothelial origin, but urothelial will be positive for both 7 and 20, ma'am. Then, ma'am, lung, TTF1 we can use, ma'am.
Yes.
Then,
So in this case, the basic message is that whenever you get a FNA from a cervical lymph node with the papillary kind of structure or papilloid structures, you have to think of the possible primaries. Okay, and then you have to see that based on the morphology, how will you exclude one by one? Somebody said medullary comal, from thyroid. Thyroid medullary can sometimes have a papillary pattern, but then again you have to pay attention on what the nuclear character. So nucleus,
yes, ma'am.
here you can see what you can see nuclei in many of these. Okay, so there what kind of chromatin do you see?
Then salt and pepper chromatin medullary thyroid.
Fine chromatin. It is a neuroendocrine tumor, so you will get a fine chromatin
Salt
in,
and
yes. So that all you have to exclude. Anything else, Dr. Shruti, you want to ask?
Yeah, so in this case, when we know that it is a papillary lesion, and most commonly it might come from thyroid, it might come from breast, or it might come from kidney, I would rather do a Paxate first than doing a CK7 or 20. Okay, so a clinical examination is of prime importance. So you should have told that we could have taken the history, like thyroid lesion hai ki nahi,
Yes.
uski history le sakte hain, radiology check kar sakte hain. We can also
You
find
should
out.
have asked these questions,
Yeah.
whether this information was present or not present, or will you ask for the patient regarding any imaging finding? Did he has this? Did he has that?
So for this patient also, we actually end up catching this patient because after much deliberation, this female told us that she had hematuria. And once hematuria ka history aaya, then we got a PET CT done only to find out that there was a renal mass. So history is of utmost importance. And when you are doing IHCs, you should choose your IHCs very wisely. Like हर में 720 नहीं लगा देंगे.
Yes.
अब जब हम thyroid सोच रहे हैं पहले, या हम renal mass सोच रहे हैं, then I would prefer to do Paxate in this patient. Paxate is positive in thyroid. Paxate it is positive in kidney, right? So we choose our markers wisely. Now we can move to the next case.
So we move on to next case. Anybody has any questions? So we go on to the second case. So second case is a 10 months old male child. He has abdominal distension for 2 months. And on ultrasound, he has a heterogeneous abdominal mass, which is obscuring the upper pole of the kidney. Now, it is obscuring, so we don't know the origin of the mass. Now, the FNA has been done from the abdominal mass. And this is the smears at the low power.
So, Dr. Dakshayani?
Yes, ma'am.
Yeah. Would you like to comment on the smear?
Highly cellular smears, ma'am. And in low power, it is showing might be the tumor cells are the cells are arranged in small sheets and clusters, and as well as discretely present. And predominantly blue cells are seen.
Okay.
Okay, so they are mostly disc cohesive cells, and then there are some of these clusters. Cohesive
Yes,
clusters are here. Okay. So now on this, in this image, can you describe this picture?
This is showing overlapping clusters, ma'am. Feels like overlapping clusters, as well as discretely arranged cells are present.
Okay. Anything else? Overlapping, why do you say?
Ma'am,
So what would be spindle shaped? Okay. What are these structures? These are cohesive structures, no? And they're forming some kind of pattern or structure here.
Papillary pattern.
Not sure at this power because this is a low power. So let's move to higher power here. So again, this is what kind of cells are here? Can you describe the cell morphology here?
Spindle-shaped cells, ma'am.
Not exactly, but because we don't see any cytoplasm here, so these cells are not exactly round, but maybe and not very spindle also, but they have a very high NC ratio. We don't see any cytoplasm.
Yes,
so maybe you can call them like round cell tumors. Okay.
Yes.
They have a little on the periphery. They have been a little bit smudged because of smearing. But if you see these cells, they look like a small round cell. So we have. You can see this one now. Now you can see these cells. Okay. So you see different kinds of cells. Again.
So do you think there is a dual population of cells?
Yes, ma'am.
Okay. So can you describe both the populations?
One population is small cells with scant cytoplasm and high NC ratio and round nuclei, and other population is
yes.
large cells with elongated nuclei, ma'am, spindle to elongated nuclei.
Okay, so maybe we don't have a higher power of these structures, but these are forming some cohesive structures, some glomerular structures or tubular structures. Okay, we don't have a core here. We don't see any connective tissue here, just like for the vessel. So these are not papillary structures. So in a 10-month-old child, if you see these, like if you see this one, it is mostly like a small round blue cell tumor, isn't it?
Yes.
Very dispersed. Most of them are dispersed as well. It is highly cellular. Some you see here cohesive clusters which are forming some structures. Okay, at high power you see these small round cells which have very scant cytoplasm, hyperchromatic nuclei, and you see more than one type of cells. So in a 10-month-old child, location is somewhere near the kidney because it is obscuring the kidney on ultrasonography. So what are your DDs?
Wilms tumor.
Nephroblastoma, Wilms tumor.
Okay.
Okay. Anything else?
Neuroblastoma. Neuroblastoma.
Yes.
Primitive neuroectodermal tumor.
Yes.
And,
A little rare in a 10-month-old child, but yes.
Peanut will be slightly lower down the list, uncommon.
Can it be a
congenital
lymphoma?
mesoblastic nephroma.
Mesoblastic nephroma. Okay.
Yes.
Yes. Anybody is thinking of lymphoma? So no one is thinking about lymphoma. Does it look like lymphoid? Okay. So you don't have that very discrete round cells, LD bodies. Here you see what different types of cells.
So what do you think what it can be? So you have a differential of Wilms tumor, you have a differential of a neuroblastoma, you have a differential of Ewing sarcoma, like peanut today. You also have a differential of lymphoma. So how do you rule in or rule out all the different ones? Dakshayani?
Ma'am, based upon the age as well as site, if you see the morphology, we could say that these are arranged in glomerulite pattern. So
Okay.
first we will do WT1,
And
ma'am.
okay. Hmm.
WT1 will be done.
Okay, so let's not jump to the IFC. Let's stick to morphology. Why is it neuroblastoma? It could be adrenal mass because it is the upper pole of the kidney.
Location is somewhere the adrenal and the kidney. So it's a big mass obscuring the kidney. So why this is not a neuroblastoma?
Ma'am, two population of cells are seen, ma'am. The
Okay.
epithelial and blastomal.
Okay.
So you have this kind of discrete cells, okay, lying separately. Someone can you switch off your mic? I think you have multiple mics on at one place. So you can see this cohesive clusters which are epithelial looking, and here you can see the other component is very discrete dispersed cells with round blue like of cell morphology. And if you go at a higher power, you don't see any cytoplasm, very scant cytoplasm. Okay. Okay.
So what can be the usual finding if you want to say something as Wilms tumor? What is your expected cytological findings? Dr. Dakshayani?
Ma'am, first we need to see the population of cells, ma'am, blastomal cells, epithelial cells, and stromal cells.
Okay.
The blastomal cells are usually discrete with scant cytoplasm and
Yes.
with the round nuclei, whereas epithelial cells usually they're arranged like rosetoid pattern with moderate cytoplasm, ma'am.
So sometimes you
And
can also see glomerulite structures or shaped structures, okay, or tubules also.
yes, ma'am.
Hmm.
And stromal cells will be seen, which are again seen discretely, spindle-shaped cells.
Yes.
So they can be a mesenchymal component in the form of muscle. They can be rhabdoid cells.
Okay. So you have to consider the age you are having a DD. Any other DD anybody has?
Ma'am, congenital mesoplastic nephroma.
Okay. So what is the morphology of a mesoblastic nephroma?
Ma'am, we will see the stromal component, more amount of
You will see
stromal.
more of a spindle cell kind of morphology.
Fascicles of spindle cells will be seen.
Yes.
Yeah. So it resembles leiomyoma.
Yes.
So you get spindle cells.
More of a mesenchymal cell population. Here you are also seeing this kind of cohesive sheets or tubules of epithelial cells, apart from these discohesive, dispersed round cells here. Okay. So this is a 10-month-old child.
So if I call it blastema predominant wills, or if I call it stromal predominant wills, or if I call something as epithelial predominant wills, does it matter?
Yes, ma'am. Prognosis varies. Prognosis depends.
Okay, so can you elaborate?
Ma'am, blastemal films can have a worse prognosis compared to epithelial.
Issue with the voices.
Shraddha, I think you have multiple mics wherever you people are sitting. Are you sitting together? Then you can just switch off you can just mute that mic. Yes. Hmm. So now tell us why the blastema, which component will has a better prognosis and which one poor?
Ma'am, blastemal predominant will have a worse prognosis, ma'am, and epithelial predominant will have a better prognosis, ma'am.
And if it is mesenchymal predominant or spindle cell predominant?
Ma'am, that will also have
those are usually resistant to therapies because they are difficult to melt. Okay. So shall we move to the third?
Yeah, so this was the blastema predominant wills
Yes.
with a very small epithelial component.
You can see more of these round cells, dispersed round cells. So the third case is a 3-year-old boy with history of progressively enlarging abdominal mass for 1.5 years. And he has a 4 into 3.5 centimeter solid mass, and an FNA was done, and the smears given to you were these images. So Dr. Ramya is there? No.
She has texted me.
Okay. Dr. Preeta?
Yes, ma'am.
Yeah. Can you please describe the smear?
Ma'am, smears are moderately cellular and they're arranged in rosette-like pattern and clusters.
Okay. Okay. What about the background?
Ma'am, it has an amorphous background.
necrosis in the background.
Okay.
Necrosis. Okay. So for necrosis, you should see some granular or powdery thing, and then you should see some nuclear debris as well. So do you see some nuclear debris like neutrophilic breakdown or any chromatin, powdery chromatin like thing in the background? No, है ना? It looks more of acellular. Acellular pinkish material, है ना? So maybe we go to the higher bar. Again here. So here, what can you see? So you have very loosely cohesive clusters, isn't it? Dr. Preeta, are you there? Okay, Dr. Sagar?
Yes, ma'am. Sorry, ma'am.
Okay. Okay, so here can you see the background?
Yes, ma'am.
What kind of background?
Fibrillary background.
Not exactly fibrillary. Fibrillary is more homogeneous, more pinkish.
Granular rather.
Huh?
Granular.
Sorry?
Granular.
Granular, okay. Does it look something like gelatinous or
Next slide
liquid?
has more. आगे वाली एक और slide has more. Last one.
Maybe this is another cluster which is again loosely cohesive and forming some structures. Okay. Then this is another one where you see something here. And this is another one. This is the last
So
one.
here you can actually see the background.
Yeah. And then again you see here something, these cells forming some structures. Okay. And you can see here it is acellular, no? The cellularity is very less, pale, nothing amorphous, huh? Mucoid-like or gelatinous, like if you remember. Huh? So this is a 3-year-old child, FNA from the abdominal mass. What are your DDs now? Dr. Preeta? So you have of morphology. You have something here where they are forming some
Rosettes.
yeah, or rosettes. Okay. Again here. What could be DD?
Ma'am, I'm not sure.
Okay. Anybody else? Dr. Sagar?
Neuroblastoma.
Neuroblastoma, okay.
So for neuroblastomas, we usually expect small round blue cells. So these cells do not look too small or too blue, to me at least.
You can see the cytoplasm here, and do they have you see the chromatin character as well? Is it very fine, homogeneous? You see the pleomorphism or the atypia, no? All of them they're like, there is a moderate atypia. Some are like oval, irregular. They're not that monomorphous, no? Monomorphic cell population we don't see here, no? And if you see the higher power, the chromatin is not that fine. It is looking like something bad looking cells. You see these cells, they don't have a fine chromatin. See the cell morphology here. They have moderate pleomorphism. No, they are very irregular. Some are large, some are round, some are elongated. Okay, but they are not spindle.
Also, let's get back to the history. This is a 3-year-old child with abdominal mass. Clinically, what are your differentials? Again, the same differentials: Wilms tumor, neuroblastoma,
Yes.
lymphoma, the similar kind of differentials.
So it is a small round blue cell tumor or round blue cell tumor. You have to think of the differentials according to the age. So will you consider mesoblastic nephroma here, Shraddha? At 3 years of age? Okay. Preeta, any other DD? Or anybody else?
So does it look like a Wilms tumor? We can just do a yes or no session. Does it look like a Wilms tumor?
No.
No.
Okay.
Good.
So does it look like a neuroblastoma?
No.
So actually, we cannot see the neuropil. Actually, we cannot see a very high mitotic
not fibrillary.
index. So I am ruling out neuroblastoma for that reason. Does it look like a lymphoma?
No.
Okay, sir. You had also talked about.
Just a minute. The neuroblastoma lymphoma will have a very monomorphic kind of cell population. Okay, you see the structures here, and they're forming cohesive and tubules as well. Okay, so lymphoma would not show you this kind of structures, no? And then we see the chromatin. Chromatin looks bad, like coarse, slightly coarse. Huh?
Yeah. So we have ruled out all these. Now you were talking about PNET. Can it be PNET?
Possibility of PNET can be taken on.
Okay.
Because we'll
with
have
respect to
undifferentiated and
okay, so it is undifferentiated. That works for me.
So at this age, you can think of any other Primaries, can it be from liver?
Hepatoblastoma.
Hepatoblastoma.
Hepatoblastoma. So it can occur at 3 years of age. Anything else? Any other mesenchymal tumor?
Rhabdomyosarcoma.
Yes. Which rhabdomyosarcoma? If you have this kind of round blue cells, which rhabdomyosarcoma would you think of? And the age is 3 years.
Embryonal.
Embryonal rhabdomyosarcoma. So all these come clinically in the DD. But once you see the background, so should you continue?
Yeah. So let me just drop a hint for all of you. So this child had a undescended testis. So what are the tumors which you expect to arise from an undescended testis? So this was the abdominal mass, but then this child had a undescended testis, which was later found out on examination. Now, what are your differentials?
Seminoma.
Seminoma.
3-year-old.
Embryo.
Think of the age. He is a 3-year-old boy and has the lesion for last 1.5 years. Okay. Would you like to know something from the clinician? So you just now got a history that this child has a undescended testis. Now, would you like to ask something else to the clinician in this morphology?
Markers,
by
AFP.
Yes.
Yes.
Yolk for we can suspect yolk tumor.
So you will ask for AFP
Ma'am,
alpha
AFP
fetoprotein.
levels.
Okay. Any other marker? Okay.
So this child had an AFP of 1000 international units per ml. Now your suggestions?
So can AFP be raised in in which tumors you can see raised AFP? We just discussed few of the DDs. So one you said yolk sac. Any other tumor which can have a raised AFP?
Hepatoblastoma में AFP का क्या होगा?
Increased.
Okay. So by seeing the morphology with the clinical correlation, with the clinical history that you just got, now what is your DD?
Hepatoblastoma.
Hepatoblastoma. Do you see these cells are hepatoid? Do they have the cytoplasm in hepatoblastoma? There are different types of hepatoblastoma. So usually it is very well differentiated hepatoid, look polygonal, and you will see some cytoplasm. Here, do you see cells like that? And then the background, it is giving you some kind of granular gelatinous background, no?
Ma'am, yolk tumor.
Yeah.
Okay. Okay, fine. So anything else you would like to ask?
No, so for yolk sac tumor, you should also search for Schiller-Duggal bodies.
Yes.
So in FNA, we can find Schiller-Duggal bodies. So you should look for them.
Sometimes you can see that here we don't have a very good Schiller-Duggal body, but you can see the this nuclear character, no? This looks like very irregular coarse chromatin kind of nuclei and a little bit of like you can see the ATPI. It's a bad looking cell. Hepatoblastoma doesn't show cells like these, okay? And it will have at least moderate cytoplasm, which will be the cells will be polygonal or round. Here you don't see those cells. So if you see this kind of morphology, I think the germ cell should come first.
Yes.
In
so
a 3-year-old.
If you want to confirm germ cell, any IHC marker which you would like to put?
SAL4, ma'am.
Yes, you can do a SAL4. SAL4 is a pan germ cell marker. And for yolk sac, confirmation of yolk sac?
Ma'am, we can do hepar arginase glypican 3.
For the confirmation of yolk sac?
Yolk sac tumor.
A yolk sac tumor you said is a germ cell tumor because I am saying SAL4 is a pan germ cell marker. तो कोई भी germ cell tumor होगा उसमें yolk sac positive आएगा. I want to specify that this is yolk sac.
Yeah. AFP.
Into AFP IHC. Anything else?
Yes, ma'am.
Okay, so we move to the third case. Fourth case, okay. So this is a 54-year-old female. She presented with abdominal distension and which is gradually progressing over the 2 months. She also gave the history of loss of weight and loss of appetite, but no other clinical or radiological information was given. And we received 50 ml of turbid ascitic fluid. So now these were the smears or the images which were given to you. So who is there from other than Ames Rai Bareilly?
We have Dr. Sagar.
Dr. Sagar, can you describe this smear, please?
Moderately looking smear and cell balls, I
Okay.
can see.
Okay.
That's
So you find clusters of three-dimensional clusters of cells, a cell ball-like clusters, huh? Okay. Here. Can you describe this one, this image?
cell ball.
Okay. Do you have more than one type of cell, or you think all the cells are similar looking?
All the cells are kind of similar looking.
Okay.
Two cell population also seen as signet ring cells are seen, ma'am.
Signet ring cells.
Occasional
Okay.
signet ring cells.
Okay. So
Plasmacyte.
you have one cluster, and you have another cluster here where you can see the difference. Okay. You can see these clusters, you can see these clusters. Then we go to higher power. So here, can you describe the smear? Can you describe the cell morphology, Dr. Sagar? The cells, the individual cell morphology.
So these are 3D ball-like clusters, right? Have we lost Dr. Sagar?
No, I'm here.
Yeah.
Just
Okay.
weak in
Ball-like clusters.
My institute,
Yeah.
there are very few.
Sorry?
Now I'm kind of weak in
Okay.
slides. इसमें थोड़ा weak हूँ.
So 3D clusters, and these are like cohesive, some maybe not a papilloid cluster, but some kind of large clusters of cells with multiple, maybe forming tubules or something. Okay. So you can see these multiple tubule-like structures aggregated together.
नीचे एक सेल है जिसमें की विंडो है पीछे वाला
This one.
ये 3D बॉल क्लस्टर के ठीक नीचे
This is one. This is one.
So 6
Okay.
o'clock position.
So can you see this one, this cluster? Sagar, can you see
Yes,
these cells? These cells, can you identify what are these cells?
Also, arrow नहीं दिख रहा है.
Moving the mouse, huh?
ये थोड़े plasmacytoid जैसे दिख रहे हैं.
Plasmacytoid. Okay, can you see something in between? You don't have. Okay, so what do you think? What could be the DD here? Is the fluid normal, or what pathology does it have?
Adenocarcinoma, diffuse, gastric adenocarcinoma.
So it is cellular, okay? It is cellular, it has cohesive clusters, which doesn't look mesothelial, okay? It has ball-like clusters, 3D ball-like clusters, cohesive clusters. Then the cells which are here they have nuclear ATPs. Some are large, some are hyperchromatic with high NC ratio. Okay, so different size of cells. So if you think of a metastatic tumor, And suppose you are not sure whether these are just reactive mesothelial cells or this is really epithelial cells coming forming ball-like clusters. What cytochemistry can you do?
Can do calretenin, WT1. PAS and Alshendro can be done, ma'am.
PAS and
Alshendro,
okay. Will you
which
specify
are
more?
positive in mesothelial cells.
Will you specify more? You have to do better PS with diastase.
Okay.
Okay, so if you do a PAD stain or PS with diastase, if you find mucin in these metastatic cells, which you yourself said, that some are looking like a signet ring cell. Sometimes mesothelial cells can also show you
Signet
signet
morphology.
morphology. Okay, so when they're very florid. So I pointed out these cells. Okay, so if you see here, you can see a window in these two cells. Okay, so these are the normal mesothelial cells as compared to these cells which are cohesive and forming ball-like clusters. Okay, so if you do a PAD stain, you will find globules of mucin if it has mucin. It may not show you always. All metastatic adenocarcinomas will not show you, because if they have a scant mucin, if they don't have a mucin, they will not show you PAD positivity. Okay. Okay. Now, if you make a cell block and you want to do an IHC to differentiate whether it is really metastatic or we are just seeing a florid mesothelial hyperplasia, what will you do?
We can do calretenin, WT1,
Okay.
and MOG31.
Yes.
Hmm.
So which is positive where?
Ma'am, in mesothelioma, calretenin WT1 be positive, ma'am. MOG31 is negative in mesothelioma. It will be positive in metastatic adenocarcinoma.
Okay, so before that, what would be the possible primary sources which can give you a metastatic malignancy in the peritoneal fluid? Can you name?
Ovary, ma'am.
Patient is 54-year-old female. है ना?
Ovarian mass,
Okay.
ovary.
Yes.
Ma'am, then from endometrium, ma'am.
Okay.
Colorectal carcinoma, lymphoma, breast carcinoma, ma'am.
Yes.
GI tract, ma'am.
Yes. She said, okay. Anything else?
Lung.
Lung will show you, maybe it's very common to have a peritoneal fluid positive. It will be like pleural fluid will show you positivity more commoner. It's very, very rare to see a peritoneal fluid positive in lung carcinoma. You can have anything, but it's very uncommon. Then
Lymphomas and leukemias.
okay, so
With
in the cytic fluid with this kind of cohesive clusters, ball-like clusters, we won't think of
lymphomas.
lymphoma, hai na?
There has to be a lymphocyte-rich effusion to call it a lymphoma.
And dispersed cell. Okay, we are here. What we are seeing the cohesive ball-like clusters, epithelial structures, hai na? So again, we will go to those DDs for metastatic carcinomas. You have to know how to look for primary. So again, that panel of IHC markers, mesothelial versus epithelial, and then in epithelial, you have to look for the primary sites. Okay. So at least whenever you get a smears like this, you should suggest whether it is malignant or it's not, whether it's metastatic or is it mesothelial or is it reactive. And if it is metastatic, what are the possible sources of primary? Given the age, given the gender, you should list down your possible primaries according to that. Okay. Do we have any extra history for this patient?
No, ma'am. We just gave it as a cytic fluid, and we want to know the IHC panel markers which you guys will want to put.
Yes. So DDs, you have already told that you can have metastasis from ovaries, metastasis from GI, from breast.
Endometrium. choose one marker each for ovary, for
Yeah.
GI, and for breast.
Paxate, ma'am.
Okay.
Ma'am, GI
Data for breast.
CDX2, CDX2, ma'am, for GI.
Okay.
And
Okay.
for breast?
Gata 3, somebody said.
Okay, somebody said
Data
Gata.
for breast.
Yeah.
So if I say it is Paxate positive, do you want to do some other marker?
Ma'am, P53
WT1.
T1 can be high grade metastasis from high grade serous.
Okay.
High grade serous carcinoma. Okay. So even endometrial carcinomas will be Paxate positive. What other markers will you think if it is a endometrial causing ascites, which is not usual?
ERPR, ma'am.
Okay.
Ma'am, and CD10.
CD10 is positive in endometrial stromal sarcomas rather than
These are
carcinomas.
looking epithelial, no?
Yeah, these look epithelial.
So the easiest thing to do is first a cytochemical stain. If it is not helpful, then you go for immunohistochemical stains, okay, according to your DLEs. So we move on to the last case. Any questions here? Okay, let's go to the last case. So this is a 62-year-old male, and he has a left cervical swelling for 4 weeks. He has a history of cough and breathlessness for past few months. So he went for an ENT checkup. So no lesion was detected on his oral examination. He has a firm to hard swelling in the left cervical lymph node, which is 22 centimeters. And FNA was done, and the smears given to you were this one.
So Dr. Preeta?
I think we have somebody else. Huh? So Dr. Swati here, Swati or
actually,
Krishna? No, they are not here.
यही लोग हैं सिर्फ इनके नाम जिनके मैं बोल रही हूँ मैं बता रही हूँ यही लोग हैं सिर्फ.
Okay. No. Dr. Sagar, we can go to Dr. Sagar once again. Dr. Sagar, are you there?
Yes, ma'am, I'm here.
Okay, so can you just describe this image?
Ma'am, my basics are weak. Well, I cannot confidently describe
No,
the
at
slides.
this, I told you at low power, what do we have to see?
At low power, I can see the
Cellularity. Highly cellular. Okay, yes. And do we see any pattern? Any arrangement?
clusters of cohesive.
Okay, so we see less of discohesive cells, more of a cohesive clusters or loosely cohesive clusters. We don't see too much dispersed population of cells. Okay, correct?
Yes,
now you go to this power. Now what do you see?
These are papillae.
Not exactly. Maybe something capillaries are there. It is not very exactly a papillary because you see a lot of cells on one side of this, some fibroblastic structures. It is not forming papillae. Here again you can see some dispersed cells here, loosely cohesive structures but with some overlapping. Okay, if you see here, you can see these like sheets or aggregates of cells, which are loosely cohesive. And what else? You can see some overlapping here. What else you can see? Komal, can you describe?
Ma'am, there is a this sheet-like arrangement, loose sheet-like arrangement of cells, and they are predominantly very less cytoplasm, so appearing very bluish.
Yes. So you don't see much of cytoplasm. Not even it's very scant. You can't see any cytoplasm around these cells, Okay. What else? What about the nuclear character? And this is a 62-year-old male. Okay. What is the
Nuclear molding?
Nuclear molding. Okay. What about the chromatin?
Hyperchromatic.
Okay. It is hyperchromatic, yes. Is it granular, postgranular, fine granular, vesicular, clumped? Yes.
Granular salt and pepper like.
Good. So it is very fine. If you see the individual chromatin, you can see fine granular salt and pepper kind of chromatin. Okay. And all the cells look more or less of similar morphology. Okay. So with the given history and the age, what are your possible DDs?
And small cell carcinoma of lung metastasis.
Okay. What is the hint here? Why lung? This patient has?
And
Ma'am,
breathlessness.
history
Yes.
of
Male.
cough and breathlessness.
Okay. And then you see here what? You see these nuclear moldings. Okay. You see nuclear overlapping, nuclear molding, fine chromatin, salt and pepper like chromatin, and a history of?
Cough and breathlessness.
Yes, where you think that the lung is probably affected. Okay. So there is something in the lung which is causing all these.
Can this come from somewhere in the head and neck? Any small cell neuroendocrine cancers in head and neck?
From
Any
the nasal region.
Nasopharyngeal again, not exactly like this. It will be more dispersed with the prominent nucleoli, and then you will see some lymphocytes admixed with that. Okay.
But you do have small cell neuroendocrine carcinomas in the nasopharynx.
Yes.
So this metastasis can come from there. Sometimes these patients can present only with metastasis. They have a small lesion, but it goes to the cervical lymph node and they present with only cervical lymph node metastasis. Maybe sometimes epistaxis जैसे nasopharyngeal carcinoma में होता है वैसे भी.
So it is a small cell carcinomas can arise sometimes in head and neck, which can show you this kind of morphology.
Yes.
Okay. So it doesn't have to be always nasopharyngeal.
So any differentials apart from a small cell?
Merkel cell carcinoma.
Sorry?
Yes, please.
Merkel cell carcinoma.
Merkel cell carcinoma.
Usually have a very prominent.
They have some cytoplasm. They are more monomorphic, very round cells, monomorphic. Here what do you see here? Angulation, molding, and different shapes of these cells, overlapping. Merkel cell doesn't show this kind of morphology. Okay, it is more monotonous, monomorphic kind of population. There will be some cytoplasm in Merkel cell.
What immunohistochemical marker would you like to do to confirm this?
Ma'am, synaptophysin neuroendocrine
TTF1,
markers.
synaptophysin, chromogranin A, CD56 ma'am.
Would you like to exclude something? Any marker to exclude? These are markers to confirm. Do you have any other DD to exclude?
Non-small cell, we want to exclude.
Okay. So what do you do for non-small cell?
P40, P63 can be done ma'am for TTF1.
So this could be a very poorly differentiated squamous cell carcinoma. So to rule out that, you can do a P40.
Yeah, but again, you have to understand that here, do you see any cytoplasm? No, so if it is a very poorly differentiated squamous cell carcinoma from a lung, it will show you some scant, dense blue, deep blue cytoplasm. Okay, and the nuclei may be prominent. You will see some nuclei here. You don't see any nuclei in these cells. You don't see any cytoplasm. Okay, and the characteristic feature which you see is nuclear molding and overlapping.
You can also do a INSM1 in these cases. So INSM1 is a new marker, which is like very sensitive and specific also. So you can do an ISNM1 in these cases to confirm a diagnosis of a small cell neuroendocrine. So anything about the mitotic activity in small cell neuroendocrine carcinomas?
They have very high mitotic.
Yes. If you see here, you can find some kind of maybe like kerorexis or mitosis.
So do you have neuron other than small cell neuroendocrine matlab carcinoma? Do you have other neoplasms which have neuroendocrine like salt and pepper chromatin and neuroendocrine like morphology?
Olfactory neuroblastoma.
Okay, olfactory neuroblastoma, good. Anything else in the lung?
Thymoma.
What about carcinoids?
Carcinoma. Yes, ma'am, carcinoma.
Okay, so but they don't have this kind of morphology here. So with this morphology, your small cell carcinoma is the should be the diagnosis, and you should work according along that entity. So you should write the IC markers to prove this or to confirm this. Okay. Anything else?
No, this was the last case.
So anybody has any questions regarding these 5 cases?
I think of basaloid SCC in this last case.
Basaloid SCC, again, Komal, you have to have some cytoplasm. And then again, basaloid SCC would have very round monomorphic cells. Here we don't have that kind of monomorphism. No? We don't, this is the highest power which we are showing you. We don't have cytoplasm, very scant cytoplasm. Okay.
Anybody else in any of the cases? Any questions?
Ma'am, for the last case, can we give a DD of poorly differentiated SCC?
If you want, if you're not sure, you may write, but then you have to write the markers. How will you approach your DDs? So like if you want to have a more than one DD, maybe it doesn't fit here, but if you, even suppose if you're not sure and you write it, but then you say that what markers will you do to confirm or exclude your either small cell or your squamous cell. Okay. But again, in the absence of cytoplasm and all, I don't think you should think of squamous cell. Yes, somebody else has question?
Ma'am, somebody's writing in the chat box to please give the final diagnosis of all the cases, especially 2, 3, and 4.
Yes.
Okay, this is small cell carcinoma, metastasis from lung. This 5th one, okay? Chat box will have to write that, okay. So this is metastatic
Adenocarcinoma.
Okay, in the fluid, ascitic fluid. So if you all of you are there, you can note down. So case 4 is metastatic adenocarcinoma in a ascitic fluid. Case 5 was small cell carcinoma metastatic from lung to cervical lymph node. Then we come to case 3, which is a germ cell tumor arising in a yolk sac tumor arising in a cryptorchid testis. Okay, undescended testis. Okay. Then it has this mucoid background. This was case 3. Case 2 is a Wilms tumor, blastomal predominant Wilms tumor. Okay. And case 1 is a metastatic papillary renal cell carcinoma. So is it okay, or shall I repeat once more? So have you noted down?
Maybe stop sharing the screen.
I'll have to stop.
Ma'am, some student is writing to please repeat the diagnosis once again.
Okay.
We can write in the chat box.
I'll just write in the chat box.
Yeah.
Yeah, no, yes.
Yeah.
Also cross कर देंगे.
इसको भी.
वो नीचे messages click करने से messages आ जाते हैं. Somebody wants to know about nuclear molding. Can we explain molding?
Yeah. Here we can write. So case 1 is the metastatic
Papillary RCC.
papillary renal cell carcinoma. Okay. This is case 1. Case 2 is Wilms, blastomal predominant Wilms tumor. Okay. So case 3 is a germ cell tumor, yolk sac, in a cryptorchid testis or in an undescended testis. Case 4 is a metastatic adenocarcinoma in ascitic fluid. Case 5 is metastatic small cell carcinoma from lung, the cervical lymph node. Okay. Okay. So somebody asked about molding. I'll just open that.
Share the screen again.
So is it visible? It is not visible. I've not shared. Huh? Okay. No, I'm already sharing. Is the PDF, this PDF visible?
Yes, ma'am.
Yes, ma'am.
Okay, okay.
Yes, ma'am, it is visible.
Visible. So molding is something where the nuclei, they're opposed to each other and they are so fragile and so adjustable that they can fit according to the surface. So you just imagine about something putting in a small box, some structure which is flexible. So what happens? They have this kind of border which is opposed to each other. Okay.
Yeah, so my teachers used to describe molding as what we do in trains in our country. So the train berth is meant for 3 people, but then 6 people sit in and
Yes.
they mold each other.
Yes.
They are like एक ऐसे करके 6 लोग बैठ जाते हैं वहां पे. So वैसे ही न्यूक्लियस एक साथ एडजस्ट होके, because they are very soft and deformable, so that is why they don't have a cytoplasm. So they just like mold with each other to set in.
You can see these structures, no?
Yeah.
So if they're closely opposed, so they just fit in with each other and they try to be very closely opposed in a small space. Okay.
So this is all about molding. And somebody also asked about the marker for yolk sac tumor. So AFP
Yes,
alpha
sir.
protein is a very good marker.
Yes.
Ma'am, Dhruv is asking, could the last case be a lymphoma?
See the cohesiveness.
Also, no lymphoglandular bodies.
Yes,
in the
lymphoglandular
background.
bodies, and then you see the cohesive structure, the arrangement. Lymphomas will be, again, you will have some lymphoglandular bodies, as Dr. Shruti is saying in the background. So small blue cytoplasmic fragments. Here
And
we don't see that.
disperse.
And dispersion. Sometimes lymphoma shows you pseudo cohesion, but not to this extent. So here you see most of the clusters as cohesive clusters. Again, here, as in the first slide only, we said that there is almost no dispersion, very less of dispersion. Okay. Even if you see these small clusters, they are loosely cohesive, some are tightly cohesive. Okay. So they're tightly packed or loosely packed, but we don't see single cells too much in the background. So lymphoma will be like a diffuse population, generally single cells spread in the background. Okay. So dispersion will be 2 more. Here you see cohesive structures. So lymphoma should not be a DD here. Okay.
And if lymphoma is a DD, what IHC would you do to rule out or rule in?
CD45.
Okay.
So you would at least put one LCS to broadly categorize whether it's an epithelial or it's a lymphomatous. Okay. Anybody else? Any other question? Chat box. Link for joining the upcoming talks. Okay. I think the organizers can help you with the link.
Yeah, ma'am. Ruchi will share the link.
Yeah, sure.
Any more questions, students? Would you like to ask anything else?